So I'll start by presenting the case study. So today's case study is on a 19-year-old female lady who presented with daily episodes of dizziness or vertigo. She says that the room was spinning. The episodes would last for 10 to 15 minutes, and they were associated with headache, nausea, vomiting, and decreased hearing in the right ear. She also reported right-sided tinnitus that was of low pitch and a right-sided ear fullness that was concurrent with the episode. The patient also has symptoms of anxiety. She used to love sports, but she now had to stop the sporting activities. She also had a history of a motor vehicle accident when she was 6 years old and has a positive family history of migraines. She was also on medications. She was put on antidepressants and some mood stabilizers. Now, when you look at her pure tone audiogram, she did a pure tone audiometry, and she has a low frequency, severe, sloping up to moderate hearing loss, again, sloping down to severe in the high 8 kilohertz high frequency. The left ear on the other side, this has a low frequency, mild hearing loss, sloping up to normal, and then again dipping down to a mild high frequency hearing loss from 4 kilohertz. Her tympanogram was normal. She had on the right side, she had a type A tympanogram, but on the left side, you can appreciate that she has a type C tympanogram, and the reflexes were not done. They were unable to maintain seals for the reflexes. In terms of her vestibular and ear exam, she had bilaterally normal ears, bilaterally normal intact tympanic membranes. Her corneal reflex was the tests. Well, here it says that the corneal reflex was absent on the right side. When you look at the oculomotor function, she had normal range of movements. She had no spontaneous or gaze-evoked nystagmus. Her pupils were equal and reactive to light, and she did not have any saccades. And she had smooth pursuit of an object with her eyes. Her cerebellar function also was unremarkable. In terms of vestibulo-ocular reflex functions, the range of movement in her neck was normal. On the head thrust, she had a corrective saccade towards the right side, and her head shake was not done. However, when she had the dynamic visual acuity tests, she had a slip or an error of 4 lines, and her hyperventilation test was positive. She felt lightheaded, and it took around 45 seconds for her to get the vestibular symptoms on the hyperventilation test. In terms of the Romberg's tests, she was steady, but fell in 30 seconds. Again, Sharp and Romberg was steady, but unsteady at 30 seconds. And same on the form, she was only able to be steady for an average of 30 seconds. She did not have the Utabaga test done. Her Dick's Hallpike test is negative. Yeah, this is negative. So her Dick's Hallpike test was negative. And so the audiologist thought that she probably has vestibular migraine and Meniere's disease. So she was put on migraine prophylaxis symptoms, and then she was sent to monitor her symptoms with VNG and calorics tests. So I don't know if you want to, because now from here, this is the discussion on vestibular migraine, but I wondered if you wanted us to first discuss the history and the presenting exam.
Yeah, quick question, Lillian. So up to these events, Did she say the timing of her vertigo attacks? Did she, you mentioned there initially some of the timing, but was that documented sort of like historically what she would describe with repeated attacks? And were they always associated with pain? Or that's a, does that make
So,
sense?
her symptoms, those were her symptoms. And what you will find is that they were lasting for around 10 to 15 minutes, and she was getting daily episodes.
Mm-hmm.
Daily episodes, and they were all associated with nausea. There was a headache.
Mm-hmm.
But then she also repeated that she has decreased hearing on the right ear and a right-sided low-pitched tinnitus.
That would always come with the attack? Would they always concurrent with the attack? Would there be ear symptoms with each attack?
That I'm not really sure because I did not take the history. It was taken by Divya, but yes, that's a very important thing because it would help us differentiate whether it's a Meniere's syndrome versus a vestibular migraine or an overlap of both.
And another quick question is, do you know specifically what antidepressants and mood stabilizers she was on? Was she on anything like the Valium family, benzodiazepines or anything like that?
No. From what I saw, she was on amitriptyline. Yeah. SSRIs is what she was getting. Okay. For the mood stabilizer, I'm not so sure which one.
Okay.
I have a question also.
Yeah.
Unterberger's test, I saw mentioned. Unterberger's?
Yes. It wasn't done. It is here, and it was reported that it was not done. Not done.
Oh, not done. Okay.
Yes.
And what is the Unterberger's test?
So the Unterberger's test is also called the Fukuda test. Okay. It is the test of vestibular function where you tell the patient to stand and make steps in one spot with their hands outstretched, and then you want to look as to whether they sway. A normal person can sway up to 30 degrees, but when you have a vestibular hypofunction, you find the patient would sway up to 45 degrees and more towards the side of the lesion.
Right. I've just never, I'm familiar with the Fukuda step test. I didn't know it was also called Unterberger's, but apparently it is. That's very interesting.
Yeah, that is what it is, yeah. Any other question?
Yeah, what did you do?
Okay, now, unfortunately, for this patient, the case ends there. The case history ends there. The rest is a discussion on vestibular migraines.
Oh, we don't know what they did. Okay.
So I think it says in the plan here, they did migraine prophylaxis trial, symptoms diary, and then follow up in 3 months.
In terms of migraine prophylaxis, you mean a diet? Did you say migraine prophylaxis diet and then follow up?
A trial of migraine. No, I think she just meant the medication. We usually start them on amitriptyline.
Okay.
Yeah, routinely here they start them on amitriptyline, but then in the clinic you counsel the patient about the migraine diet. So some patients you have to take a history of alcohol taking, history of the symptoms being concurrent with taking coffee, taking foods that are rich in I'm not sure which compound, but mainly nuts, foods such as nuts, foods that are a lot of chocolate, and any other tryptophan related foods. And so you ask them to stop or to withdraw these foods, all of them at the same time, and then they can start reintroducing, coffee being the last that you reintroduce, to see whether they are related with the symptoms or they could cause a trigger.
What do you usually use, Dr. Becerra? What's your drug of choice?
For migraine, we'll start with like Pamelor. Yeah. So usually that'll be for prophylaxis. I'll start with that.
What? Sorry, what is it called?
So Pamelor, nortriptyline, basically it's the same.
Trypsin.
Right? It's a tricyclic, yeah. It's nice because it has low side effect profile. You have to make sure there's any cardiac issues. They could take it at bedtime, so it actually helps. It's a bit of it makes people a little bit tired, drowsy. So we usually give it a few hours of sleep, so at bedtime, and then start at a low dose, and you can ratchet that up for a while. And the nice thing about that is you can at least be trialing that until they get in with a migraine specialist, because once you get to the migraine medications, there are certain migraine meds that I just won't write for. Obviously, I'm not going to write for beta blockers and calcium channel blockers and some of these other types of things. So it's a nice drug to start with.
And
Yeah.
what about giving magnesium?
You can. I mean, you certainly can. I try not to give too many try to change too many variables at the same time, because then it's hard to know what was effective. So I talk about sleep, diet, exercise. Many times when you ask these patients about sleep or diet or stress level, they're usually one of those is off. So I try to, help with some lifestyle management in concordance with some of the medication, and trying to identify triggers. So just a second. You're having a fire drill or something. So yeah, so I try to address some of the lifestyle change along with that medication as well. At least you can do that. And then we're running out of people to see here for migraine management. So it kind of falls on a lot of us to help sort of manage this. So I feel like my migraine management purview is becoming a little wider now, just because the lack of people that can help manage it. So that's usually the approach. Now, in this situation, those are pretty profound unilateral ear symptoms. For somebody with migraine, it's interesting to see unilateral ear symptoms like this. Oftentimes you might see bilateral or not as profound ear symptoms this way. So here, that's the big differentiation. So we always talk about migraine being the great mimicker of Meniere's. So I'm sure you'll talk about that. But and with Meniere's, at least if it's pure Meniere's, we always talk about imaging is not necessary. But in this kind of situation, maybe I'll talk about that as well, is making sure that there's nothing, getting some baseline imaging on this one, but I'm sure you'll talk about that.
Was there fluctuation in her hearing when she wasn't having a spell? Did her hearing get better? Do we know that?
It's not very clear in the history, but it's quite clear that she had all the symptoms that fit the criteria for Meniere's. She has oral fullness, she has tinnitus, and she also has the vertigo, which is classic. Okay, not really classic, but it lasts around 15 minutes and it's associated with nausea and vomiting. The funny thing is that she's also a almost perfect patient who fits the criteria also for vestibular migraines, because she has a family history of migraines. She's a patient who has all those other symptoms of anxiety. She has headache, she has vomiting and nausea, and her symptoms, her disease symptoms have now limited her function. She's now not having sport activities. So I don't know, but she looks like a patient who has a little bit of everything.
Another good ask, particularly in women, reproductive age women too, is asked, are the symptoms worsened around menstrual cycle?
Yeah.
Because many times with a lot of the hormonal changes that come with that cycle, obviously those can be triggering effects for migraine as well. So I always ask, particularly women and reproductive age women, do these symptoms worsen at that time? Sometimes people say absolutely. It's if it comes right before the cycle and bang, they get some kind of an event, a headache or some kind of spell, that kind of thing. So that's also an important thing to ask and try to correlate timing wise. That can also help you because Meniere's won't do that, right?
Yeah.
So much. That you may be thinking about more like migraine when you have that kind of pattern. Yeah.
Okay, just before I go to the discussion, is there a role for monitoring the symptoms using calorics in this patient? Because in the management, they said that we'll monitor the symptoms with VNG and calorics.
You mean like if they're as they come up, like routinely, or just?
Yeah, when they come back in 3 months to follow up. Do the migraine prophylaxis or the migraine medication, does it help with the like, can you monitor that with the calorics?
Well, I don't think so. No, I don't think it's going to reverse. It's not going to reverse any damage to the inner ear. So other than symptoms, you wouldn't repeat VNGs each time. I wouldn't do that necessarily. That wouldn't be an indication. You'd want to know what the symptoms are. Are the symptoms better with the treatment? But it seems to me like she's got obviously it looks like you had a corrective saccade. It looks like she's got a unilateral, at least some kind of vestibulopathy.
Yeah.
That may or may not be compensated for, which is why she's having some issues. That's why I was asking about drugs. So certain drugs will prevent central compensation, like the benzos or meclizine, that type of thing. But I wouldn't use it to monitor. No, you'd want to just see how the symptoms are. And then you'd want to get her into vestibular therapy, obviously to work on compensation and then trying to prophylax against some of these triggers. But again, the key here is, I think the underlying theme, and you'll probably mention this in the discussion, is really, is this Meniere's, is this migraine, or is it both? You know, she's pretty young for Meniere's to be coming on, 19, right? That's fair. That's kind of youngish. Although it does manifest earlier in women, but that's fairly young to get Meniere's.
Yeah.
So that's another tip off that maybe it's migraine. But those are the things that, you know, I have patients do a lot of home journaling to kind of document symptoms, because at least with Meniere's disease, it can take months to make a diagnosis because it's a symptomatic, right? It's an episodic symptomatic situation that doesn't come on every day. Now, you said this is happening daily. That wouldn't be consistent with Meniere's. Meniere's would be rare to have a daily effect. So that's another thing to think about. And then the timing. It's kind of short. If she's, you know, short spells, they're a little shorter than their typical Meniere's attacks. So
I also wondered about the timing vis-a-vis migraine, because she seems to have her episodes do not fit the migraine criteria. 15 minutes is again a very short duration of time.
yeah, but usually if you look at the migraine literature, be short, they have such a broad range. So you look at the migraine literature, they'll say 5 minutes to 72 hours.
Mm-hmm.
So it's quite the broad range, whereas the Meniere's criteria a little tighter. That's usually like 20 minutes to 12 hours.
Okay.
But migraine is usually shorter in my experience, or longer. And it's the periodicity of it as well. So like I said, you know, Meniere's you're not going to get Meniere's attacks every day. That's just not in keeping with the natural history of the disease. But migraine, you certainly can. Yeah. Mm-hmm.
One other thing that I think is helpful too, in terms of keeping track of things, your journaling, I think is really helpful. But I also will sometimes ask them to video themselves when they're having an attack, especially their eye motions. It's sometimes helpful to see what type of nystagmus, if any, they're having during an attack. And I think particularly it's useful, and somebody may have bilateral disease, if they have bilateral Meniere's, to figure out which ear is active during the attack and so forth. But I've had some patients send me some pretty wild videos.
It's easier now than ever with phones.
Yeah, with your own phone, yeah.
Mm-hmm.
If you're not throwing up too hard, you got somebody can video it for you.
Right.
Okay. So some facts about vestibular migraine. The term vestibular migraine was coined in 1917, and it is characterized by episodic symptoms of severe vertigo that can come with or without headaches and significantly interferes with the quality of the patient's life. The female to male ratio is 5:1, where the age of onset is higher in females as compared to male. Mean age is 37 years for women, 42 years for males. And most of them have a family history of migraines, and the migraines are, the vestibular migraines are associated with their worsened during the menstrual cycle. They also are associated with Meniere's disease, BPPV, anxiety, and depression in the patients. So of note is that 14% of the population have migraines. That is the incidence of migraines in the general population. However, only a very small percentage of these people present with a vestibular migraine. What has been shown is that more than 50%, or an average of 50% of patients who develop vestibular migraines have had at least one episode of migraine before, or more episodes of migraine before. So most of them usually have a history of migraines. Also, around 27% of patients who present with who have Meniere's disease can present with vestibular migraines at some point in their life. In the pathophysiology, this is a very complex image. Even I myself cannot explain it, but I know that the main pathophysiology of vestibular migraines is activation of the trigeminal vascular reflex. And this trigeminal vascular reflex loop is usually activated, and it affects, or it causes vestibular symptoms through the ophthalmic branch of the trigeminal nerve, where it has a concurrent, the blood supply usually through the anterior inferior cerebellar artery, and the nerves usually follow that to supply the cochleovestibular nerves. And at the same time, this is the same artery that also supply the artery loop that supplies the vestibular nucleus in the level of the medulla and the pons. And so activation of this pathway usually leads to release of vasoactive substances, neuropeptides, and this causes the hypersensitivity of the vestibulocochlear apparatus in that region, and it causes the patient to experience the symptoms. There's also the pathway, the same pathway is also involved in the thalamocortical processing pathway in the level of the amygdala. And this now brings together all the symptoms and the correlation between vestibular migraines and depression and anxiety and other cognitive behavioral problems. And that explains the whole triad of the symptoms that the patient presents with. Depending on how much of it is involved, then the patient can present with headaches, can present with the visual spatial symptoms, which are not necessarily vertigo, and some of them can also present with even the vertiginous symptoms. Now, the criteria for a definite vestibular migraine, the patient must have at least 5 episodes, that is 5 episodes of migraines with a concurrent past history of migraine with aura or without an aura. Then the vestibular symptoms should be of moderate or severe intensity, and they can last between 5 minutes and 72 hours. And at least 50% of the episode should be, 50% of the episode should be, have at least one of the following 3 features. That is either unilateral location of the symptoms, pulsating quality, moderate to severe intensity, and should be aggravated by routine, or they should be inhibiting the routine physical activities of a patient. Also, to add on to that, we have the other 3 criteria of the migraines, where there can be photophobia or phonophobia, and the patient can present with an aura. I don't know what's happening to my slides. So we've just talked about the criteria for a vestibular migraine, but why is a vestibular migraine missed is that because most of the times patients have symptoms that overlap. it is also missed because sometimes the patient might have a headache but not have vestibular symptoms, and sometimes the patient has vestibular symptoms without the headache. Also, the variability in the accompanying symptoms, sometimes the headache or the aura or the vestibular symptoms can occur after the headache, and sometimes they can also come before the headache, or they can overlap. Patients also can present with some auditory symptoms that are usually mild in nature, including tinnitus and some form of hearing loss. Also, you need to do a neurological examination and neuroimaging so that you can exclude other lesions, because the symptoms can overlap with symptoms of other neurological or neurosurgical symptoms, including some psychogenic symptoms or psychological symptoms. So the reason why it matters to diagnose the patients with vestibular migraines is that the vestibular migraines are associated with lower quality of life in the population. 40 to 60% of patients miss work or school due to these symptoms. There's also an overall impact of up to 50% effect on their daily activities. So most of them are reported to have the migraines interfere with their day-to-day activities, and up to 52% of the patients have experienced falls. So when the patients are misdiagnosed, vestibular suppressants are commonly prescribed, and this now delays the institution of migraine-specific symptoms, and the patient keeps having the symptoms, which again affect the patient psychologically, and the patient becomes more redundant. And this now makes the patient also become more, or rather to be more sedentary, which worsens the vestibular compensation. So it is sort of like a continuous positive feedback kind of loop with the patient. So when you're taking the history of these patients, you want to find out how long does the headaches last, or how long do the symptoms last? What are the associated symptoms? Does the patient have cerebellar symptoms? Because of the pathway, you want to rule out symptoms of any basilar strokes or any other cerebellar infarct that could be happening. So dysphagia, dysarthria, paralysis, unilateral paralysis. You also want to find out about photophobia and phonophobia. Also, the relation of the headache, or the relation of the symptoms in relation to movement of the head, to rule out other vestibular symptoms, such as conditions such as BPPV. You also want to find any triggers, any aggravating or any relieving factors. And you can also use the Barani Society Criteria Diagnostic Questionnaire, which can help you go step by step and diagnose the patient. I'm sure both of you are familiar with this. I don't know if you use it in your clinics, but these are the questions that are in the Barani Society Questionnaire for Vestibular Migraines, and they go step to step. So the symptoms of vestibular migraines are mainly lightheadedness. Then we have headache that can come after their dizziness has subsided most of the times. They also can have hearing changes or tinnitus. They get nausea, vomiting, and they also have some symptoms of fatigue or generalized tiredness. Or they actually say that they feel like they are having a cloud on their head or over their head. That is a sensation that they describe. We also have motion sickness or sensitivity to any form of visual stimulation, and sensitivity to sound or light. In the physical examination, you want to do cranial nerve exam, cerebellar exam. You want to do the exam when the patient has the symptoms, and you can also do during the attack-free periods, though you can have quite negative symptoms when the patient is not having an attack. Of note is that positional nystagmus of central origin can occur in 10 to 20% of patients, and so this is something that you can find in these patients. So The Dix-Hallpike maneuver, usually when you do the Dix-Hallpike, you'll find that the patient, it can evoke dizziness. However, the patient usually does not have nystagmus. When you do other vestibular tests, you find that the patient has hyperactive calorics in 50%. 50% of vestibular migraine patients have hyperactive calorics. The head impulse test is usually abnormal. So some of the patients can have a corrective saccade, and the patients have abnormal or absent ocular and OVEMP, that is ocular VEMP responses. Postulography is also normal, and pure tonodrometry can show some sensory neural impairment. But this is not a very common presentation in patients with vestibular migraines. And of note is that due to the blood supply of the cochlea, the patient usually present with a high frequency vis-a-vis the low frequency kind of hearing loss that you find in Meniere's disease. They have a high frequency sloping kind of hearing loss that is most of the times mild. And this is in around 7.5 to 10% of the patients. So neuroimaging is quite important, as you have mentioned, and it is usually normal in patients with vestibular migraines, but it can be used to exclude other causes of central vertigo. It can also be used to exclude other causes of vestibulocochlear symptoms in patients, such as strokes, posterior circulation strokes, and any demyelinating disease. So this is just the BPPV, which is a differential, which could be a differential of the vestibular migraines due to the duration. And then these are the symptoms of Meniere's disease. So Meniere's disease, they have fluctuating unilateral hearing loss, they have episodic vertigo spells, they have aural fullness, and their tinnitus is usually a low frequency roaring kind of tinnitus. Now, in vestibular migraines, the patient feels dizzy. The dizziness lasts around 5 minutes up to 72 hours. Typically, the dizziness of Meniere's usually lasts around 15 minutes to up to 12 hours. Then the patients with vestibular migraines have photophobia or phonophobia, and they usually have symptoms that are caused by visual hypersensitivity symptoms. So you'll find that they'll tell you that their symptoms are worsened by moving objects, or they are worsened by watching TV, or by colored things, anything that is visually stimulating. Their symptoms also cause what they call spatial disorientation. So instead of describing the classic dizziness of Meniere's that is associated with spinning of the room and vomiting, the patients who have vestibular migraines most of the time talk about feeling like they are swaying on a boat, or feeling like they are floating, or feeling like their head is displaced, or their body is displaced in place. This is characteristics of the three diseases: the vestibular migraine, Meniere's disease, and BPPV. And this is basically, I think, what we have just been talking about. In terms of differential diagnosis, our differential diagnosis could be any occult intracranial lesion, acute vestibular neuronitis, acute labyrinthitis, multiple sclerosis in females. This is quite common. And then brainstem neoplasms, some transient ischemic attacks, especially that affects the posterior circulatory system, vitamin deficiencies, especially vitamin B1, Wernicke and Wernicke-Korsakoff encephalopathies, heavy metal poisoning, and some metabolic abnormalities. So these differentials will be guided by the age of the patient, the symptoms of presentation. That will definitely help you try and classify. Of importance is that patients who have vestibular migraines also have concurrent, my laptop has gone out of charge, but I think we were at the end. But these patients usually have concurrent usually these patients have concurrent psychogenic symptoms. And so even when you're treating the patients with vestibular migraines, you want to use a multidisciplinary approach. So it's been shown that most of them will have symptoms of anxiety, symptoms of depression. And so this is related, or this has been found to be associated. And when you're managing them, not only do you send them for vestibular rehabilitation therapy, you also can send them for some cognitive behavioral therapy and some psychiatric evaluation because of the positive loop we talked about. Now, the last thing we are going to say is the management of patients with vestibular migraines. You want to find out or rule out any triggers that could be present, and the triggers could be present from their lifestyle. So sleep deprivation, stress, anxiety, any any sleep deprivation, any stress, any anxiety, this tends to activate, or this tends to worsen the symptoms of this patient. We have food triggers and alcohol triggers. So patients, especially red wine, chocolate, coffee, and nuts, and any other food that could be related with the triggers. And so when you're talking to these patients, you want to have a stepwise kind of approach. So you can start by looking at their lifestyle and diet, and you try to see what can be modified. Also, it is important to look at the mood of the patient, to rule out anything that could point to the patient having anxiety or stress symptoms, because this could be associated with their migraine attacks. And then after that, you can go to migraine treatment of the migraine symptoms themselves. So the medical treatment, you can either give them migraine prophylaxis, which could be in form of magnesium, or you can give a low dose amitriptyline. You can start with even 25 milligrams. Patients have also been shown to respond to norepinephrine and serotonin reuptake inhibitors, and also some of these drugs. They're used to treat neuro drugs for epilepsy. Yes, they're called neuroleptics. Yes, those drugs for epileptic. So you can also use medication for epilepsy in these patients. Ultimately, these patients usually need a multidisciplinary kind of approach. So you want for you to help them with their vertigo, they need to have some form of vestibular exercises or vestibular rehabilitation, so that you can help them to compensate. So you want to start by treating the attacks, treating the migrainous episodes, and then now you can proceed to doing some vestibular rehabilitation for them to get over their phobia of fear of falling. And then now you can also do sustained migraine prophylaxis treatment. And if it is needed, then you can also send them to a psychologist to treat their anxiety and anxiety symptoms. I think that is the end.
Discussion.
Nice job.
You know, the one thing that you mentioned, and I think that it bears repeating because it's so important, just that the overall incidence of vestibular migraine is so much higher than Meniere's disease. And I think that for most of my life, you know, I was really looking more for Meniere's disease, but the overwhelming number of people that have vestibular migraines, you know, I think that, particularly in a case like this where it's a little unclear, but she's got so many, you know, localizing symptoms and everything, I still think that, you know, attacking vestibular migraine high on the list is important, just because of the gross numbers of patients that suffer from migraines is so much more than true Meniere's disease. And so I think it's really an important topic, and I thought you did a really nice job of reviewing it very thoroughly. Thank you.
Thank you.
Yeah, I agree completely. Nice job. You know, unfortunately, migraine, it's not a one size fits all, as you guys have probably learned, that some meds will work for some patients and then others, they won't be responsive. So it creates you have to build a really good relationship with these patients, because you're kind of in it for the long haul to some degree, because sometimes it can take months to find something that works. And as you said, many times they'll have layered diagnoses. They might have Meniere's on top of migraine. And then if you throw in SSCD, they can also have symptoms there too. So some people may have pulsatility, they may have some chronic disequilibriums from that, and then you're trying to layer that on top. It can really get challenging to manage some of these folks, and it can take months to figure out the diagnosis and even longer to figure out what the best treatments are. So that's where the documentation becomes really important. Homes, symptoms, all these different things. Yeah, it's very challenging. But I always ask these patients about lifestyle stuff, because at least in the States, a lot of people more and more have sleep apnea, they have poor diets, they don't exercise, they have a lot of stress. And so all these sort of lifestyle things confound whatever might be also organically going on in terms of the etaology. So you're constantly trying to compartmentalize and separate some of these things that are contributing, but at the same time, they're all sort of contributing, so I think there's a lot of educational opportunity for these patients as well, in terms of, things that they may need to change in their day-to-day lives that can potentially have a huge impact on their quality of life. So
I also think that your discussion with them about anxiety, whether that's something that is associated with the trigger or whether it's an effect of the disease. I mean, they go hand in hand. It's like the chicken and the egg. You just don't, there are very few people who have these kind of symptoms that don't have some anxiety associated with it. And the fact that you are assisting them in a systematic way to get these things under control can help relieve their anxiety, just by the fact that you're working with them and you tell them, yes, we have things we can do to fix it, to prevent it, and we're going to work with you until we get it under control. Just that reassurance sometimes helps some of the anxiety, because a lot of people think they're dying. I mean, they just don't, or they have these symptoms every day, and it's such a drain on their life that the reassurance that you give them by working with them is really helpful. I think that what you said, Greg, about having a hard time getting neurology involved is actually a problem throughout all of the United States. We just have too few neurologists for a lot of neurological problems, and we're really fortunate at my institution to have three neurologists who are part of the department that see patients with these issues, and a couple of our neurologists do as well. Because there's just so many of them. I don't see them. I used to treat them in my practice before I came here, but because we have in-house people, it's just been really a great blessing. They're really good at helping to take care of them. But we have a shortage of good neurologists. I mean, we have good neurologists. They're just so slammed. They have 6-month waiting list or more, and it's really hard to get in to see them.
And so it puts makes it more important that we're understanding this and we can manage it more on our own, because I think to serve the patient, it's hard for the patient to go that long waiting to be managed, at least trying something.
Yeah.
And unfortunately, even if you do have neurologists available to you, some, believe it or not, they don't believe in vestibular migraine. They actually don't believe that exists. So you're sitting there going, So not only do you have like this paucity of providers, but then the ones you do have, some of them are like, well, I'm not really sure this is actually a thing. You're like, oh, okay, great. So it can be really challenging from both sides, of the patient provider relationship. So there's a lot of nuance to this. But I think, Lillian, you guys, this is really an important topic that, because you're going to see a lot of this in your clinics, as Brad mentioned. And just getting a good fundamental approach on how you work it up and communicate with the patient and, therapeutic options. It's really important.
Having a handout sheet of dietary things that they can do. I mean, you've mentioned it several times. The elimination diets are really, I think, a very helpful thing to start with, and people can work on that. If I think there might be overlap with Meniere's, I might also have them go on a low salt diet. But if you take away chocolate and coffee and wine and cheeses and nuts and salt all at the same time, it's pretty much, all they can eat is cardboard.
All the good stuff they can't have.
All the good stuff, you just take it away. Just take it.
I tell them if it tastes good, don't eat it.
That's right. Yeah. Yes, it is hard. You have to set realistic expectations. So like with my Meniere's patients, I tell them what the goal sodium would be, but I always tell them you need to document what you normally would eat in 3 days. And then I want you to cut that down by a third over the next month and then sort of taper down, because to go from 6,000 milligrams of sodium a day to, 1,500, that's a monster change for a lifestyle for people. And, you're kind of setting them up to fail. And it's a lot like the migraine diets too. You just have to be realistic about what people are going to observe or respect and give them realistic goals. Say, okay, maybe you should just start looking at some portion control over the next month and then document symptoms, that kind of thing. So
Yeah, I actually do it a little, I kind of do it the opposite way. I
Yeah.
tell them, look, I say to people, if it's for migraine, and not for migraine, for Meniere's disease, when I tell them about a low salt diet, I tell them, look, some people are exquisitely sensitive to the sodium in their diet, and some people aren't. And I want you for the next 30 days to go to 1,500 milligrams a day, watch every label, read everything, really be strict, and let's see how it goes, and see if your symptoms abate at all. And some people, I mean, most people can do it for a month, but it's
interesting.
and if they don't, if it makes no difference in their symptoms, then I say, well, we'll relax a bit. I kind of back off. But some people will tell me, oh, I was doing fine with my Meniere's, and then I had a piece of country ham, and it's loaded with sodium, and I had an attack the next day. And so I think it's nice to know how much effect something like that has. And I think the way that you discuss the diet from migraine is also a very reasonable approach, where you go to elimination and you start adding back things and see how they affect them, and maybe specific triggers can be identified that are useful. I think it's a very practical approach. So and it's nice if you can find something you can avoid in your diet rather than going on triptylines or other medications that can have their own set of side effects. So that's
Now,
kind of
so in this specific patient, though, the hearing loss wouldn't necessarily be explained by the migraines.
it can be. It can
can
be
be. Okay.
Yeah.
But I'm always suspicious
unusual,
of
but
it,
it
though.
can be.
I'm always suspicious of that, though, really. But it can be, though. Yeah.
The other question I wanted to ask, this is another patient we saw today at the Dizzy Clinic.
Sorry to interrupt you, Lynn. I have to run to the OR, guys, but I'll let Brad you guys can chat. Sorry to.
Okay, no problem. But I'll text you
job.
about, I'll forward an email from a gentleman who wants to start up the cholesteatoma guidelines.
Oh, perfect. Excellent. And Tashneem and I are going to chat tomorrow about that too.
Yeah.
So
he reached out to me. I'm going to, I think I'll tag him in the email and forward it to you. And then
that's perfect.
Yeah, you can communicate.
That sounds great. Sorry to cut you guys off. I better run. So. Good to see you guys. Stay warm. Stay cool.
Thank you. Yes.
Depending on which hemisphere you're in.
Yeah.
Appropriate weather precautions based on whatever hemisphere you're in. All right. Bye.
Yeah.
Guys.
Okay. Thank you so much. Bye.
Bye.
So Brad, sorry, our temperature is currently around 6 degrees, but it feels like 0 to me.
It's very warm and humid here today.
Oh, okay.
It's about 85, 90 Fahrenheit and high humidity.
Wow, 85. That's high, yeah. So I have this, we saw this patient at the Dizzy Clinic today. She's a patient who has a history of a vestibular migraine that was diagnosed in 2014. And she got stereotactic radiotherapy for the migraine. And she subsequently has been having pain. And this kind of pain is, she has dizziness, she has vertigo from the vestibular migraine. And at the same time, she says that she has a pain that is on the side of the lesion. That is, she has a right-sided lesion. On that side, she has complete or profound hearing loss. She has vestibular symptoms, but she also has this characteristic headache on the same side. And so the headache is quite severe. It comes almost every other day. And she has of course, she has many other issues that are causing her symptoms to be worse, including some anxiety and some psychological issues. But my question was geared towards the headache. When patients undergo stereotactic radiotherapy, she actually had a cranial nerve fallouts on that side after the radiotherapy, but now they have improved significantly. She now has a House-Brackman 3 facial nerve palsy. It's still improving. She had a hypoglossal palsy, which has totally resolved. She had a vagal palsy that has resolved. But the headaches, are the headaches associated with the radiotherapy, or are the headaches due to the lesion, the vestibular schwannoma? I could not understand why she has this characteristic right-sided headaches that are like burning in nature, and they are constant. They come every single day.
How long ago did you say she had the radiotherapy?
2014. It's been like 10 years.
10 years.
Yeah.
Wow. Are they associated with, you said they're always right-sided, they're always the same?
She says it's right-sided, and she actually describes it as scalp pain. It is, she feels it inside her head, but on the scalp.
Yeah, that's unusual, isn't it? It's also interesting that she had so many other cranial neuropathies with the radiotherapy. How was it delivered? What type of radiotherapy did she get? Was it just Linac or?
No, she got stereotactic radiotherapy with a Linac.
With the Linac.
Yeah.
The fact was it a large tumor?
Well, moderate, not very large tumor. Yeah.
It's lasted for 10 years. Wow, that's sad. I'm not sure, I typically tell patients that vestibular schwannomas are not responsible for pain. I mean, I very seldom see patients that have vestibular schwannomas are responsible for pain, but stereotactic radiation can damage the trigeminal nerve as well. And it sounds like they got quite a bit of other cranial neuro. I mean, the whole side of the basal side of her brainstem sounds like it got some extra radiation. It's a fact she got some lower cranial neuropathies as well. And so I think it might be trigeminal neuralgia that's been induced by the radiation, but I'm not sure what you do about it. I mean, I don't know. Did the tumor respond? The tumor's not growing, or it's...
No, the tumor has not been growing. It actually responded. 10 years later, it's the same size.
Yeah. I would ask, if I'm sure in 10 years she's probably done everything, but I would say ask the neurosurgical group that treated her if they think that this could be some kind of trigeminal neuropathy, and see if they might think there's anything they could do from a microvascular decompression standpoint for her headache pain. Now, the fact that it's over her scalp and not really over trigeminal distribution is a little bit odd as well. And so maybe I'm barking up the wrong tree to say it's trigeminal. I mean, it sounds like it's more scalp, but yeah, you have to think.
She actually had some trigeminal symptoms because she reported some decreased sensitivity on the right side of the face, also on her trigeminal nerve exam. Yeah, she said the right side was less sensitive than the left side.
Yeah, it sounds like they got some spread, to their field that was unintended. But scalp pain, I don't know. I mean, one thing I would consider in something like that, and may be unhelpful, but if it's scalp, I might consider local injection with an anesthetic and see if you can make the scalp pain go away. If you could inject her somewhere in the scalp with lidocaine and have it temporarily resolve her symptoms, that would be really wonderful, because then you could have the anesthesia. At least here we have anesthesia people, put in an alcohol block or something that's more permanent. But it's hard for me to relate a cutaneous type of a nerve issue in the scalp with radiation. But on the other hand, she does have a lot of other things that got damaged from her radiation, so it may be useful to think about something like that. If there's a trigger point that you could give a local anesthetic to. I find there are occasionally times when people have a cutaneous lesion in a nerve someplace that will respond to lidocaine, and I'll usually, if I'm going to inject it, if they can say to me it hurts right here, you know, if they can localize it to one finger, I'll inject that and put some steroid in with it as well in case it's an inflammatory type of a response. I don't know that. I mean, honestly, that's the kind of a patient where I say you've got to see a neurologist that deals with headaches, because they may need a pain cocktail. They may need something to help just keep their symptoms in check. There may be nothing procedural that we can do. And I'm not a good headache doctor. I mean, I am sympathetic and I try to do some limited things, but I also think that for people who have long-term daily severe headaches, they need to have somebody who can help them manage their medical regimen to keep them from, you know, from having, you know, a lot of side effects and so forth. So I'm sympathetic, but I don't feel like I have much expertise when it comes to treating chronic daily headaches that are severe like that.
Okay.
We occasionally we will have some patients, you know, after a suboccipital tumor resection that have quite severe headaches, but they generally resolve over time. You know, within a year or two, they kind of fade away. And I still will involve the neurologists that do pain management for them if they have prolonged headaches like that. But they do usually get better. But 10 years after radiation, whew, that's wicked. That's many, you know. I used to have a professor when I was a resident who would say, you know, all people can stand some pain for some time, but most people can't stand pain all the time for, you know, every day for a long time. And that's very, how's she handling it? She must be pretty distraught by the whole thing, huh?
Yeah, she's actually seen several doctors. She's on antidepressants. She's actually on fluoxetine. And she was started on amitriptyline, which doesn't work. So she recently just came back from the UK, where they started her on some cyclizine. And she says that the cyclizine is helping the headaches and it makes her vertigo episodes better, but she still has the headaches. So we sent her to the pain clinic.
Yeah, well, that's encouraging. They found something that helps a little.
Yeah.
Yeah, I'm sorry, I don't feel like I have any expertise to lend to this one.
It's okay, no problem. I think I needed the view on the vestibular schwannoma and how they react to the radiotherapy in the long term, because we wondered if the pain could be related to the tumor, especially the radiotherapy that she got. But I know that the side effects could not last that long.
Yeah.
There should be some pattern of diminishing, so it wasn't making really much sense to me.
Yeah. Difficult case. Yeah. All
Okay.
right. Well, have a good weekend.
Thank you. You too.
Thank you.
All right.
Have a good day.
Thank you.
Bye.
Bye.
Bye.